Welcome back, class. We're going to jump into the second segment of our discussion about hospitals and their systems, and we're going to spend the rest of probably this segment and one other. It'll probably take two of them to get all of what the text considers institutional. You may hear hospitals referred to as institutionals. You may hear them referred to as facilities. You may hear them referred to as, bricks and mortar. A lot of different definitions. But if you go back and think about it from a payer side or a provider side, all medical services are typically billed either on a UBO4, Uniform Billing Form, or a CMS 1500. Of course, as we've talked before, CMS is the acronym for Centers of Medicare and Medicaid Services. So, government agency that monitors Medicare and Medicaid services. So, CMS has a 1500, and a 1500 form is utilized to bill for healthcare goods and services by non-institutional or non-facility type providers. Orthotics, prosthetics, laboratory, freestanding radiology, physicians, some ambulatory surgery centers, if they're freestanding, they're billing probably on a CMS 1500. Durable medical equipment, anything that is non-institutional, that invoice from the provider or the request for payment, depending on how you want to refer to it, is going to come in from the provider into the payer. And at that point, the payer is going to start their process of determining what the accurate payment amount is going to be. So, but let's go back to the UBO4, where we're talking about institutional. So, the UBO4, it's about, I can't remember, I want to say there's 80 or 81 pieces of information that's collected on the UBO4, or the hospital bill. And if I remember correctly, last time I saw it, unless they've changed the colors were like blue and white. Whereas on the 1500, CMS 1500, they're red and white. So individuals, especially if you are seeing a hard copy, a paper copy of the claim, most claims are going to come in electronically anymore. But if you happen to see these mom and pop, especially healthcare providers that are still generating paper claims and sending them in, you automatically know just by looking at it, even if you don't understand the format, that if it comes in by blue and white, it's going to be a UBO4. If it comes in red and white, it's going to be a CMS 1500. So that's the way that, at least, that's the way I think about the differentiation between an institution and a non-institution. Institution, when somebody says institution, I typically think of inpatient hospital services, outpatient hospital services, anything ambulatory surgery services that are physically in that building with the inpatient services, lab, radiology, any of these services within the walls, within that brick and mortar, or otherwise billed with the tax ID of that hospital or that institution, should be coming in on a UBO4. And when we're talking about hospitals in general, hospitals are the most important. They are by far the most important institutional setting. They're classified according to length of stay, major service provided, type of ownership, what the tax implications are, how they're financed, size, and you typically see size differentiated 100 beds, 100 to 499 beds, and then 500 or greater, 500 or plus beds. as far as financing and taxable or IRS kind of designations, you're talking about for-profit or not-for-profit. When you talk about maybe the length of stay / major services, you usually think of things like acute care, tertiary care, long-term acute care, which are similar to skilled nursing type facilities. You have rehab hospitals, you have children's hospitals, you have cancer hospitals, you have soul community hospitals, just a lot of different types of hospitals, types of services provided in the hospitals. But the one common denominator of all those hospitals is more than likely they're going to be billing on that UB04, and that's the way they're going to invoice the payer, and that's the way they're going to request to be paid for those goods or services provided. And then Dolores talks about community hospitals, and she says they are short-stay general service facilities. And again, hospitals can either be for-profit or not-for-profit. They can be government-owned. Think of VA facilities owned by the Veterans Administration. Think about the military treatment facilities on a lot of your military bases. They're owned by DOD. State mental health facilities. Also, you see some state kind of community, state-owned kind of community hospitals in some states. So government can own hospitals depending on which states they are. Number of beds, number of hospital, actually number of hospitals and number of beds, and occupancy rates have been declining, especially in the acute care setting. And one of those reasons is that quality of care, reimbursement to providers has made it more financially lucrative that a lot of services are starting to shift to the outpatient setting. And I'll just take a hospital setting. So I go into the emergency room. And so in a hospital setting, you've either got kind of emergent care, or you've got care where you have, and I'll call them elective surgical care. So you've gone into your doctor's office and he says, man, your knees are shot. You're going to have a knee replacement. That's typically thought of as elective care in a hospital, and that can be scheduled. There's been kind of this huge upswing lately on I'll call them OBGYN, obstetric kind of services, especially birthing centers, where delivering babies is somewhat random. Even though you have kind of a due date, moms will have a due date, and the mother and father, or the however the family unit is put together, will take birthing classes, and they'll focus on that delivery date. But it's not. Trust me, it's not an exact science. Our son was, I think the expected delivery date was after the first of the year, and he was born on mid-December. So I mean, it's not an exact science, but there has been a move, especially if you're getting a C-section, a cesarean section, that they schedule them, and they pick the day of the week, they pick the time of day they want them, and they can go to the hospital, and labor can be induced, and it's a C-section, and it's a surgical procedure, and everything's taken care of, and it's not a normal vaginal delivery, and it takes all the randomness out of delivering babies. But still, you've got just a lot of surgical procedures are moving to the outpatient side of the house, because it does research tends to imply that quality of care is better if you can have it done on the outpatient side, rather than having it on the inpatient side and being susceptible to sepsis and what they call hospital acquired conditions, falling out of the bed and breaking a bone or contracting some type of disease that just permeates hospitals. So because of this shift to the outpatient surgical side or to the outpatient side just in general, the number of acute care beds and the number of, the occupancy rates are just decreasing. And you have some hospitals that have decided that they don't want to provide any acute care services at all, and they have switched to what they're termed super clinics. And you do see this, especially on military bases. Some of your smaller military bases that are remote, they can't financially support a hospital, or there's not enough demand for the hospital on base, and they're turning those hospitals into super clinics, and individuals that need inpatient care having to travel a distance to get it. Types of hospitals, again, I've gone through it. You have psychiatric, children's, cancer, rehab, TB. You've got specialized children's hospitals. You've got St. Jude's. You've got Shriners Hospital, specialized services, contractual financial arrangements. We talked in one of the earlier classes about medical tourism. You see a lot of health plans and a lot of individuals, especially private pay individuals, are deciding to go to the Far East to get their services, or deciding to go to Europe to get their services. So just the number of acute care hospitals, number of beds in the hospitals, and occupancy rates are just decreasing in the United States. And then DeWars talks about physician-owned facilities might have a competitive advantage, and a competitive advantage from the referral aspects of hospitals generating a demand for the hospital services. You've got physical therapy centers, surgical centers, diagnostic radiology centers, again, super outpatient clinics. And at some point, you have to be really careful, and payers especially have to manage this kind of self-referral issue. My job at Blue Cross Blue Shield was what they call payment integrity, to make sure that the claims that were coming in from providers were paid accurately. We had to watch providers to make sure they weren't trying to game the system. A lot of dollars, on claims coming in, and you found hospitals, and so you found institutions and non-institutional providers, both sets of providers trying to game the system and trying to generate revenue where revenue might not have been warranted based on the information on the claim. And if you started comparing the information on either a UB04 or a CMS 1500 with the actual medical record and services provided, you found a lot of discrepancies. Some of them were, honest mistakes, but a lot of them, it was just providers trying to game the system. And a lot of individuals in payment integrity, they kind of look at it as, providers are guilty until proven innocent. When you've got providers submitting claims, and let's just go back to Buffalo. So in Buffalo, Blue Cross Blue Shield was probably 45% of the market. And if I saw, especially providers that were generating claims, and if you looked at billable hours, it appeared that they were generating, 20, 30 billable hours a day. I mean, it makes no sense. And what they were doing, they were using, physician's assistants, nurse practitioners to service patients, and they were all billing on the provider's tax ID number. So as a healthcare professional, trust me, you see a lot of different occurrences. So again, if you're on the provider side, you want to make sure that your providers, say you're an office manager, you want to make sure your providers are generating claims accurately, because you don't want to be compliant in a fraud, waste, and abuse scheme and a fraud, waste, and abuse criminal case, unless you want to, be wearing those very fashionable orange jumpsuits and generating license plates at a all expense paid correctional facility somewhere along the way. And to go back to the referrals, when I was in graduate school at Ohio State, so if you've ever been to Columbus, there you have the center of Columbus, and Ohio State's not really downtown. It's, I don't know, probably a mile and a half, maybe downtown from the hospital to downtown Columbus, maybe a couple of miles. I can't remember. But surrounding Columbus is the outer loop. And Columbus was smart enough, Ohio State was smart enough, let's say, that they established these, they called them Mid-Ohio clinics, scattered around, the outer loop and, some of the outlying areas. And they were, basically urgent care clinics, and you'd go in, you'd see them. And if it was something that, you needed an emergency room services, first thing they did is they shot you down to the hospital at Ohio State. And it was generating workload both on the outpatient side of the hospital, and all those emergency services ended up in inpatient services. So again, referral patterns, especially in an institutional type setting, are extremely important from a revenue perspective. And then if you look at the second slide that I talk about on an institutional setting, we get into teaching hospitals affiliated with, medical nursing schools. They provide research, training, and education, residency programs. Many are university, some are VA owned, in major metropolitan areas, higher costs, more services provided, ER clinics, high level of indigent care. And one reason it's a high level of indigent care is they're wanting residents and interns to have as wide of array of potential episodes of care as they can. If I think back to San Diego, so University of California, San Diego was a medical school in San Diego, that teaching research facility, and not only did the residents and interns get to work there, but UCSD provided residents and interns and even physician services to the local VA facility there in San Diego. Same thing with Stanford and Palo Alto in the VA facility. So you see a lot of teaching and research facilities also providing physicians and medical expertise to VA facilities. And again, they're in large, usually larger metropolitan areas. You don't typically find a teaching research facility out in the boonies somewhere. Maybe a little different if you're in the Golden Triangle. Golden Triangle in North Carolina, you've got North Carolina State, you've got Duke, you've got the University of North Carolina. So there's a lot of healthcare services concentrated in that Golden Triangle. But you get out into the state in North Carolina, you're not going to find too many teaching research hospitals. The federal government provides direct overhead payments, stipends, salaries, grants, indirect, additional, types of payments. If the hospitals are seeing Medicare, Medicaid individuals, and they use that to subsidize these teaching research facilities. And then, DWARS jumps into, as I've mentioned a time or two, prospective payment system. And typically, I think you think of prospective payment system as the diagnosis-related grouping type system that went into effect in about 1983. And it mitigated hospital expenditures. It alleviated some of the third-party payers generated, or most of the revenue. So it was just a prospective payment system. And while it is not an absolute guarantee of what the final payment will be, based on diagnosis codes, and I'm talking about admitting diagnosis codes, potential surgical procedure codes, a hospital can get a fairly good idea of what their final payment is going to be. Now, if things go south, or if there's what they call cost outliers, so that the bill charges exceed certain levels, there could be additional payments. And I want to stop there for just a minute and talk about the contractual side of hospitals, or contractual side of institutions. So if you were to look at and I'm going to talk about a managed care contract. If you looked at a managed care contract, it's usually broken into addendums or appendices, and it's going to talk about inpatient services, and then it's going to talk about outpatient services. And inpatient services, for inpatients, admissions, let's call them, they can be paid as bill charges, they can be paid as DRG, they can be paid as, all-inclusive case rates, can be paid as per diem. And then if you flip to the outpatient side, again, they can be paid as bill charges. They can have some case rates, especially emergency room case rates in there. They can have, since you're not spending the night, you're not going to have any per diem rates, but you may have a pseudo per diem rate that's associated with what payers and providers refer to as observation stays. So you go into the emergency room, they're not sure what's wrong with you. They put you on a gurney and roll you into a hall, or they may have enough room in the emergency room that they pull the drapes around you. And they have what they call observation opportunities to observe you, to run lab tests. And if they just determine that you need to be admitted as an inpatient, you're rolled out of there and taken to a room. If they decide that you're not going to be admitted as an inpatient, then they discharge you home. And a lot of times outpatient hospital contracts will either pay, a bill charge amount for that, or they may pay on an hourly basis. So you just have, and then you'll have outpatient surgery kind of tier schedules in there based on the outpatient surgery procedure you're getting. The hospital gets a prospective payment amount for those outpatient surgical procedures. So if you're on the provider side, if you go into healthcare on the provider side, expect to be negotiating a pretty extensive array of goods and services on that hospital's contract. And on the payer side, you can expect the same thing. So it's not a simple negotiating a fee schedule. You're negotiating a lot of different levers in that fee schedule. And then when Dolores is talking about on the institutional setting, she talks about economic welfare benefits from competition, but competition depends on the number of firms, the nature of the products, the barriers to entry, the level of available information. And with the exceptions of kind of children's and maybe cancer centers, hospitals may not fit the competitive model, and most healthcare services are purchased locally. And that's where I'm talking about children's and cancer centers. I think I mentioned earlier that cancer hospitals are so specialized that you think of the cancer hospitals in the United States that, kind of people talk about. You got Johns Hopkins, you've got Presbyterian in New York, you've got Fred Hutch in Minneapolis, you've got MD Anderson in Houston, you've got City of Hope in LA. And those are the specialized types of cancer facilities that your health plan may send you to if you have certain types of cancer. Same thing with children's hospitals. There's not a children's hospital in every town. I'm assuming there's a designated children's hospital somewhere in the Nashville market, but a lot of children's hospitals are just rolled into just the regular hospital services within a given metropolitan or a given urban area. I think of Buffalo. It's Oshad, Women's and Children. It's Oshad Children's Hospital, but it's just an additional building that's added on to Buffalo General Hospital in the city of Buffalo. So, depending on where you're located, if you need specialized cancer services or specialized children's services, your health plan or your provider may refer you, and there may be some travel, just like Shriners or St. Jude's. There may be some travel involved. One thing, and I'm going to kind of digress a little here, but one thing to remember is when we talked about oligopolies, one last time, I think it was a time before we talked about monopolies and then maybe some oligopolies. But what you're finding more and more of is hospital systems in a urban area. I talked about San Diego, and you've got Scripps and you've got Sharp. Those are the two big 800-pound gorillas in that market. Yeah, you've got UCSD, and you've got the VA facility. You've got, our Children's Hospital in San Diego is actually somewhat affiliated with Sharp. But you've got Mercy Hospital, and you've got some few little smaller outlying hospitals. City of Buffalo, you have Mercy, and you've got Kaleida, the two big 800-pound gorillas there. They've formed, and it's from a bargaining power, from a market power, they are essentially oligopolies. They're going to try to drive price through branding and advertisement, and what they end up with is kind of, I'll call it mutual interdependence. And you'll see economists talk about mutual interdependence when they're talking about oligopolies. And basically what that's saying is, if you go into a negotiation situation, so let's say you're working for a health plan and you go to negotiate that hospital contract, you're negotiating it for, if you're with Mercy in Buffalo, you've got, 4 or 5 hospitals in that system. If you're Kaleida, you've got another 4 or 5 hospitals in that system. So you're negotiating this fairly complex contract for a hospital system. And what mutual interdependence means is that the decision on a contract that Mercy makes not only impacts Mercy, but it could impact the contractual relationship that Kaleida has with the health plan. Because if Mercy negotiates some really aggressive rates and gives a health plan a really good deal, then the health plan is going to expect those same rates when they go to negotiate with Kaleida, and vice versa. Same thing with health plans. In the city of Buffalo, there was Blue Cross Blue Shield, about 45%, and the other 55% was made up of Excellus, which was another Blue Cross Blue Shield plan out of Rochester, had some unbranded business there, and there were a couple of little regional plans. Centene had some business there. So the other 55% was kind of split up. And it's the same thing with health plans. You have this mutual interdependence that, depending on what you do with any group, any given provider, it could actually impact the negotiating power and negotiating strategies of other health plans in the area. So, economics is a huge driver when it comes to not only the health plan side of the house, but the hospital side of the house. Prices, and you see this more and more for employer groups, you'll have pricing and benefit plans that employer groups buy from a managed care organization or a health plan. So the health plan goes out and they sell a benefit plan to an employer group, and they say, we've got 3 different types of networks. We've got a platinum, we've got a gold, and we've got a silver. Platinum's, the best price, it's the highest quality, but it's going to cost you more money. And then you've got the next step down, it's the gold, and they talk about quality and price and access. And then silver's kind of like, well, still got some good providers, but, it may not be up to the standards of platinum and gold. And the employer group's deciding how to, which of these benefit plans and which network to purchase. They're looking at their budget constraints. And the same thing when a health plan sets them up with providers, they are negotiating. It's basically price discrimination. They're negotiating with provider groups, and they're saying, if you sign up and give us a good rate on a platinum, we will ensure that we'll send you more business your way. Kind of the gold and the silver. So there's a lot of negotiating strategy going along. There's a lot of pricing components going on. And it sounds overwhelming and complicated, whether you're on the health plans, or whether you're on the payer side, or whether you're on the provider side. But if you go into healthcare and end up in those situations, it's just a matter of stepping back and doing what? Following the money. And then what the other thing that and Dewars talks about it a little, but what you're talking about with these different prices is you're driving supply and demand. And not only that, you've got to be concerned, and we talked about referrals a few minutes ago. You've got this supplier-induced demand, which talked about earlier in the class, earlier in the one of the earlier chapters, and it's demand inducement that could result with financial issues. So, as both the provider and on the payer side, you've got to be aware of how these referral patterns look, depending on how those claims are coming in. And then you've got not-for-profit hospitals utilize tax benefits. There's no shareholders. They don't have to worry about earnings per share. They have to make sure they have enough profit to maintain financial viability and to continue to provide services going forward. But they don't have shareholders, complaining that earnings per share aren't what they are. And they have also the right to transfer assets. And then on the next slide, the Dewars comes back and hits on, because of asymmetric information, consumers prefer purchase their care from hospitals without a profit motive. And it's a perception among consumers that a not-for-profit doesn't necessarily have a profit motive. To me, it's not a valid perception, but at the end of the day, that's a perception. Profit maximizing hospitals will not produce if the marginal revenue is less than the marginal cost. And then what you've got is a lot of this marginal cost is going to be driven by biomedical research, medical education, public health is less than optimal. So you have a lot of factors driving that marginal cost. And then you have physicians or agents select the services purchased from not-for-profit hospitals, and hospitals compete for physicians' patients. So again, admitting privileges, referral patterns, and you have to be really concerned about how patients, especially if you're on the payer side, how those patients are being driven into the hospital setting. If you're on the provider side, you're going to have to worry about revenue, not only referrals from patients coming to you as let's say you're an orthopedic or cardiology or neurology specialized group. You have to worry about referrals coming to you, but you also have to worry about and make sure that you can maximize your profits based on the referral patterns that you're generating to certain hospitals. Profit maximizing operational strategy applies for not-for-profit too, because of operating margins, and you want to make sure the revenues minus the cost are positive. Again, they don't call themselves profit maximizing because their tax designation is not for profit. but they're still going to try to drive. They still have to have a positive outcome, or they're not going to be financially viable and not going to remain in business. Must produce sufficiently to survive or identify entities to subsidize their inefficiencies. As far as I'm concerned, you shouldn't be, you don't want to ever be in a situation in a healthcare environment where you're depending on somebody else to subsidize your financial viability. And with that, we're going to stop. There's just too much information to put into one video. We'll stop and we'll come back and we'll finish up this particular chapter talking about the institutional setting. See everybody in a few minutes.